All right, everybody, welcome to USD, Sanford School of Medicine. It's always such a long way to say that. Pediatric Grand Rounds this week. We're delighted to have Dr. Chuanpit Moser, our pediatric pulmonologist here at Sanford Specialty Clinic. She's a clinical professor in the pediatrics at the University of South Dakota, Sanford School of Medicine, Department of Pediatrics here. So Dr. Moser received her doctorate of medicine at Prince of St. Clair. I'm sure I did not say that right. University. Perfect. Okay. University in Thailand, moved on to pediatric residency in the Children's Hospital of Oklahoma in Oklahoma City, and then finished her pediatric pulmonology fellowship at the University of California, Irvine at Miller Children's in Long Beach at Memorial Medical Center, correct? Okay. She's moved around the Southwest a little bit and had a stint in Indianapolis and back in Thailand a little bit, but luckily we were fortunate enough to get her to come to us in 2012, not 11, 12. So 11 years we've had the joy of having Dr. Moser. She has served on numerous committees in the medical school. She's been a core member of our pediatric residency program. She's been on our pediatric care monitoring committee. She has played a huge part in our CF treatment studies and is a clinical researcher doing up to 20 studies here at Sanford. She's a huge patient advocate. She volunteers and serves others through Feeding South Dakota, the CPCM, and Children's Rights Foundations in Thailand as well. So we're just really grateful she's taking the time here today to out of her busy schedule to teach us and remind us about pediatric asthma and give us an update on management. Thank you. Nope, those are both mine.
Thank you, Dr. Whalen, for a very kind introduction. And it's my pleasure giving the talk here today. And you guys can hear me okay? Okay. Are you guys pretty familiar with asthma management the way it is now? Okay. And I'm sorry, I'm pretty short, so you might only see that much of my head beyond the monitor. So first off, just to let everybody know, the best place to get information, update, guidelines and all, there are two guidelines that we use on everyday basis. One is Global Initiative for Asthma, or short for GINA, G-I-N-A, and the other one would be the National Asthma Education and Prevention Program, short for NAEPP. And GINA is a work of collaboration among experts around the world, and NAEPP is mostly, among experts in the US. These two guidelines usually agree with each other. I shouldn't say usually. I mean, they follow the same scientific evidence, and therefore the guidelines come out to be very in sync. Any differences would be just minor. Sometimes it's just practicality of which medications are available in USA, so on and so forth. And NAEPP is not updated as frequently as GINA is. That's why I think it's kind of nice to know the one that is very frequently updated. The last update on NAEPP guideline was in 2020. For GINA, they update twice a year. And when I agreed to do this talk, it was 2022 update. And maybe, sometime in July, they came up with 2023 update. So I actually had to oh my God, I have to read the new stuff too. I don't think there's much difference though between 22 and 23. So you go on this website, you type in GINA, and then wham, you got choices. And these all are free for personal use. Here you can download the whole report, 300 something pages if you're interested. with lots of references if you want to even read more. And then there are some pocket thing that you can have in your office in case you need to refer to. And then there's booklets separately for severe asthma management. The focus for today would be this one, what's new, all about the update. I assume that we all are quite familiar with standard asthma management, the way we have been doing for the last 3 decades. So what's new?
So far down on the bottom there.
Okay. So basically, let me get myself familiar with this. Okay. So I did not really have to make my own slides. This is so convenient, 37 slides or something. So I might click past some that are not what we're focusing on today. So goals of asthma management, we want to control symptoms. We want to reduce the risk of severe exacerbation, of frequent exacerbation, hospitalization, death, that kind of thing. And so be reminded that whatever asthma management track we use is always back to the wheel of reassess, adjust if needed, review. And this goes on every time we see a patient with asthma. Now, I would like to look at this 12. So in asthma management, we put patients in 3 categories by age group. So the first age group would be 12 years and older, all the way, adults. And then the middle group would be 6 to 11 for GINA, 5 to 11 for NAEPP, but roughly, 6 to 11. And then the last group would be under 5 or under, actually, the NAEPP, the middle group could be applied down to 4 years of age. And then the youngest one would be the last group. I think the most prominent change of management, or update, I should say, most prominent update of management falls for the patients 12 years and older. And which is why this slide gives you the comparison of the upper one, track 1, is the preferred management plan. And this is where the updates are. And then track 2 is the alternative plan, which is more of the traditional asthma management plan that we have been using for the past 3 decades. So I would like to focus on the new thing. Step 1, so this is the track 1 preferred controller. The way we used to do in the old days is that we see the patient with asthma. We make the diagnosis, obviously, which I will not touch today, diagnosis. And then we would try to categorize the patient's asthma according to the severity. And we would say mild, intermittent, mild persistent, moderate persistent, severe persistent, so on and so forth. Well, that is out. We no longer see the patient and grade their asthma, because when we grade mild versus moderate, I think there are quite a bit of discrepancy among medical providers, even the same doctor, the same patient on different day. It's just the consistency is not quite there. And also because the term mild asthma could be misleading, could give false sense of security that, oh, my asthma is mild, I guess I can skip my medication, or I'm not at risk of going into a scary asthma attack that I heard of because my asthma is mild, which is not the case. And there might be some slides later on that will give you a bit more of the evidence why I said so. Looking at patients with severe asthma exacerbation, study have shown that over 30% of those patients in severe asthma exacerbation actually before that attack was categorized as having mild asthma. So that's why we don't do that grading anymore. Nowadays, I still find that it is helpful in terms of communication among medical providers to put something in the patient's chart so that people can take extra precaution. So I do use problem list to try to communicate that through. For example, history of acute respiratory failure. That is something important. PICU admission, May 2019, things like that. And then if we really want to put something for communication's sake, we do that retrospectively, meaning you first manage the patient's asthma, you take control of the asthma, and once it's under control, how much medication it takes to control patient's asthma, that tells you the asthma severity. So having said all those, we still use step 1, 2, 3, 4, 5 for the youngest group, 1, 2, 3, 4. Now, when we see patients, we still need to answer this question. Is the patient's asthma under control or not? This is still the question that we have to, this is the meaning of review. Review the patient's symptoms, lung function, and all that, medication adherence and all. Assess, is the asthma under control? And then adjust if needed. So there are 5 things that will tell us whether the patient's asthma is under control. Number 1, having daytime symptoms. If patients have daytime symptoms more than twice a week, asthma is not under control. If patient needs to use bronchodilator to relieve asthma symptoms more than twice a week during the day, that is not under control. If the patient wakes up at night because of asthma symptoms, that's also not under control. If the patient has acute exacerbation, usually we say more than once a year, that's not under control. If the patient cannot do physical activity, be it sports or play, that is also not under control. Lung function is abnormal. That is another factors of not under having asthma not under control. So if you say everything passed, everything that I said, good, then asthma is under control. If fail, say 2 out of everything, then it's partially controlled. If fail more than 2, then it's uncontrolled. What is important, what is meaningful, I don't have to say partially controlled or completely controlled. To me, it's under control or not. Because if it's under control, you can continue that treatment plan. You can even step down if the patient's asthma has been under control for 3 months in a row. If it's not under control, then you need to find out why. Does the patient take medication? Is there a problem accessing the medication? Too high copay? Are they stretching out the medication like some people have to do? Are they not taking it because of why? Do they take it the right way, the right technique, the right equipment? There are so many inhalers in the market now that it could be quite confusing when it comes to technique. And then any comorbidities. Is there allergy that we're not addressing? Is the patient exposed to, heavily exposed to allergens causing everything to flare up? Is the patient having chronic aspiration we don't know about? All those things. And then, assess all those and try to adjust. Find a problem, fix it. And if patients taking all the medications as prescribed, right technique, right everything, nothing that is not being addressed, then you need to step up on the stepwise therapy. Okay, so, and after you adjust the treatment, make the patient come back for follow-up between 1 to 3 months. It depends how worried you are. And so track 1 is a new way preferred by both GINA and NAEPP. In the future, if patients with asthma can actually have access to the right medications, treatment of asthma will be extremely simple, especially for primary care provider. Very simple therapy, and I'll show you why. Step 1 and 2, the patients who have milder symptoms. And what's the difference between steps 1 and 2? How do you tell apart your step 1, your step 2? If you have asthma symptoms more than twice a month, 2 times a month, or if you wake up at night because of asthma symptoms, then you are not step 1, you are step 2. So step 1 is like asthma symptoms so few and far in between. Step 2 is what I said. It is so simple with the new management plan because you don't really have to tell them apart, because look at it. Steps 1 and 2, as needed, only low dose inhaled steroid formoterol. So I don't even have to remember what Dr. Moser told me today about the 2 times a month. And as needed, ICS formoterol. ICS stands for inhaled corticosteroid. What has been mostly studied would be the budesonide and formoterol. I try to not use any trade names. Do you guys know what I'm talking about when I say budesonide and formoterol? Okay, do you need me to say trade name? You do, thank you. So, Symbicort. So Symbicort is budesonide as inhaled steroid. Formoterol is the long-acting beta-2 agonist or long-acting bronchodilator. Together, they are commercially available as generic or trade name, and that's Symbicort. So that is the most studied combination. And in Europe, they also study beclomethasone and formoterol. We don't have to worry about that. We don't have that in the US. In the US, we also have another combined inhaler that has formoterol in it, but the steroid is mometasone, and that is Dulera. So the key here, when you want to use the new way of management, the key ingredient is you want to use the long-acting beta-2 agonist that is formoterol only, nothing else but formoterol when I talk about long-acting with the new way of management. The inhaled steroid, we don't really have much information on mometasone, but because of limitation caused by insurance company not giving people what we order every time. So mometasone plus formoterol, which is Dulera, becomes an option if Symbicort is not covered or not available for the patient. So NAEPP is US based. It does mention that you can use mometasone plus formoterol if you don't have access to budesonide plus formoterol. One would need to understand that inhaled corticosteroids come in many, they have kind of like the same profile, but not exactly the same. They don't do the same job, microgram to microgram, and there are so many little factors that may affect potency, effectiveness, and all that. Roughly same profile. So one would have to keep in mind that mometasone in Dulera is more potent than budesonide in Symbicort. Okay, so look at this reliever. The reliever, the recommend reliever is low dose ICS and formoterol meaning Symbicort. And then if you are step 1 and 2, you use it as needed. There's nothing else that you need to do more. So patient would get prescribed 1 inhaler, that budesonide plus formoterol or Symbicort, and then use as needed. We'll talk about dose later. And then step 3, who would need step 3? If you have asthma symptoms on most days, say there are 7 days in a week. If you have asthma symptoms 4 days or more in a week, then you have asthma symptoms on most days. Then you go in step 3. And also keep in mind of the risk, risk. If the patient has higher risk of going into severe exacerbation, for example, the patient who was hospitalized because of status asthmaticus before, especially in ICU, so on and so forth, they belong here. So step 3, what do? We do low dose maintenance, same inhaler is still that budesonide formoterol, aka Symbicort. Do the low dose maintenance, and whenever the patient has symptoms, they use the same inhaler as needed. Again, we'll talk about the dose later. So if someone is already on step 3 and asthma cannot be under control, then you go on to step 4, meaning you increase that maintenance dose, and the as needed dose is still the same. Super simple. Step 5, send to the experts. So if the patient's already on step 4, and like I said, good adherence, good technique, then it's time to refer the patient to expert to look at phenotype, what kind of asthma, how about biologic treatment, long-acting muscarinic antagonist, so on and so forth. So now track 2, I'm not gonna go over track 2 today because track 2 is basically what we are doing. You can just take a look at the slide yourself, okay? And then, anybody has any questions on this one? We talk about that now. Some terminology just for the sake of communication. And when you read papers. So Gina used terminology of when you are on maintenance dose and then you use it as needed, the same inhaler that I mentioned, they call it MART, maintenance and reliever therapy, MART. NAEPP, call the same thing, SMART. They add the S for single at the beginning, so it's SMART. And it means maintenance plus PRN, meaning step 3 and beyond. For the patients who use only as needed, then they use this term, AIR, stands for anti-inflammatory reliever, meaning every time you have symptoms and you use reliever, you get anti-inflammatory therapy at the same time. Why did they recommend this? It comes on the few more slides. Okay, this one we'll skip. It's the current treatment. So, evidence. This is the evidence. Why did they recommend the new approach? So compare, this is why recommending as needed low dose inhaled steroid and formoterol instead of short-acting beta-2 agonist or albuterol, because studies compared the two and found that risk of severe exacerbation was reduced by 60-something% using as needed low dose budesonide with formoterol. This is outstanding. And then compare with maintenance low dose inhaled steroid. For example, fluticasone or budesonide, and then use as needed short-acting beta-2 agonist. Comparing the two, if you look in detail, this is basically step 2 of the old way. Step 2 of the old way, you do low dose inhaled steroid as maintenance, and then you do as needed short-acting beta-2 agonist. On here, in general, they are comparable. If you look in little detail, maybe low dose inhaled steroid is better, but by just a little bit. Then there's more study on more slides, Cochrane. Actually, they say maybe the new way is a little bit better. But all these studies, basically, they are quite comparable. Risk of, when compared, this is again step 1 and 2, as needed low dose budesonide and formoterol. Risk of severe exacerbation compared to only albuterol as needed. So as needed albuterol alone, that's basically step 1, right? Reduce risk of severe exacerbation by 55%. Now, this is risk of emergency and hospitalization compared with SABA alone, 65% reduction. Compared with daily ICS plus as needed SABA, 37% reduction. So it's kind of like, why? Go ahead.
Probably because I'm old, so I'm having a hard time reading this. So are they saying on the new way, you don't have to have a short-acting broncho and albuterol inhaler?
Yep.
Correct.
Yep.
Okay, I'm gonna freak out a little bit.
Yes.
I know, right? We'll talk a bit more about that. Yeah, we'll talk a bit more about that.
So I'm not the only one.
I went
No.
through the
Okay.
freaking out already,
Yeah.
and I started out with being extremely selective. Like
Yeah.
I still select my patients who goes on track 1 or track 2. So I'll share with you a little bit more. And you know, there's also a hidden problem when we prescribe low dose inhaled steroid for step 2 patients and then as needed albuterol or short acting beta-2 agonist. The hidden problem is adherence. How many percent of patients with asthma do you think adhere to that prescribed management plan? 0?
Not many.
Not many.
20%.
So the research say greater than 50% of patients are not adherent to the management. And it depends which paper you read. It would say 65% not adherent. And when I say not adherent, we're not even talking about 100%. We use, generally speaking, when we talk about adherence to medication, 80% and beyond would be considered adherent. Some paper might use 90%, you know, so basically 80-90% or higher would be adherence. Basically, more people are not adherent from my experience. Whenever I review and I find someone who's adherent, I'm like, wow, this is great. That means I don't see it often. Dr. Jan can give me some input. Rare, right?
Yeah. No, she's right. I think it's
It's
80% is asking too much from patients nowadays. It's like
Mhm.
they're really excited if you see anyone like 80%.
So okay. So so by allowing patient to take as needed, you know, step 1 is as needed, but as needed combination therapy is better than as needed albuterol alone for step 1, for sure, like so much better. For step 2, you can do low dose inhaled steroid, as needed SABA, or you can do as needed low dose budesonide and formoterol. They're quite comparable if the patient uses inhaled steroid every day. But if the patient's not adherent, wham, the new one is definitely better. Now, I think this is a lot. Step step 3 and 5, you guys can read some more on the website. This is the evidence behind the recommendation of treatment on steps 3, 4, 5. Basically, there have been so many studies around the world that I haven't even read those studies in detail, but at least the summary of the study results is that, for example, this one compare same dose inhaled steroid with LABA, for example, fluticasone with salmeterol or Advair, and then as needed albuterol compared to the new one or MART. Favor SMART is from NAEPP. So favor SMART, all the studies that they mentioned. And this one compare with higher dose of ICS LABA, say higher dose of Advair with as needed albuterol, favor SMART. And this one, they just put together conventional best practice, still going toward favor SMART. And this graph is quite nice too. This axis, y-axis, is percent of patient with severe asthma exacerbation, and then the x-axis is time. This one, as needed, short-acting bronchodilator. So you'll see that it takes shorter time for more patient to go into severe asthma exacerbation. And then the blue line is as needed formoterol. And then the red line is as needed budesonide plus formoterol. So asthma is chronic airway inflammation. So this is your chronic inflammation level. And every once in a while, that chronic inflammation level has some acute inflammation on top. So your inflammation go that much. So if you treat the chronic inflammation using this much inhaled steroid, it's good, right? And then something happened, inflammation goes up. That much inhaled steroid, no longer good enough. But then inflammation can come down too. So any system that can self-adjust makes sense. And we see patients, how often with my schedule, I can see patients usually, once they're established every 6 months. A lot of things can happen during this visit and the next visit. So self-adjusting regimen makes total sense and has been proven to be more beneficial to the patient. And there I also saw, I might not have the slide. I also read paper about, how, I'm sure, Aaron, you do that too, how I might say, take Flovent, 1 puff twice a day when well, 2 puffs twice a day when sick. Because I know that this patient's asthma usually is triggered by a respiratory infection. This regimen works, but studies show that if you do 1 flat dose inhaled steroid versus 2 level of doses as prescribed by the provider versus this newest way of self-adjusting, meaning you add steroid in the rescue, in the bronchodilator. So whenever they do bronchodilator, they get inhaled steroid. That one is best. Middle one is second best. And this one is least good. And it's just the matter of adjusting for the level of inflammation.
Is there a reason that in that study they used terbutaline instead of albuterol?
Europe.
We use albuterol, but
Yeah, it's Europe.
Sure.
Yeah, a lot of studies, they use like albuterol, they call it salbutamol. So when you see sal, got to be careful. Are they talking about salbutamol, which is albuterol, or salmeterol, which is long acting? And then terbutaline, we use IV, but in Europe, they also have inhaled.
so similar efficacy then.
Hmm?
So like similar efficacy from an inhaled treated to
Comparable, terbutaline and albuterol, comparable. It's such an old drug. I think terbutaline may give you a bit more tachycardia and such. But Dr. Whelan uses it IV continuous, right? If they survive IV continuous terbutaline, they can handle some inhaled. So,
See any insurance issue? issues was they're using this.
I'm sorry.
Inhaler as needed. He hit the point regarding insurance coverage about Symbicort.
Insurance. Okay, good question. So that's why I started my talk about asthma treatment can be so simple if patients have access. I know South Dakota Medicaid is super generous. I usually get whatever I order covered, South Dakota Medicaid. For private insurance, hit or miss. Some say yes, some say no. And that is a big challenge for me in terms of asthma education. Because when I see my patient, it's 1 hour deal because I did asthma education. And in asthma education, I have to teach them how to take that, basically teach them asthma action plan. So if I know for sure that this patient can have one inhaler system, this is my teaching. But if I teach this way and then send the patient to pharmacy, tomorrow they call me and say, I can't have Symbicort, can I use that? Now the teaching is like, very different. That is a big challenge. That's why I don't just put everybody on track 1. I kind of try to guess what they can have. And I also I select my patients. For the patients who tend to overuse their bronchodilator, I don't do this track 1. For the patients with anxiety, and they don't necessarily, they think this is asthma, but it's not asthma, I don't do track 1. For patients whose perception of asthma is poor, track 1 might not be good either. And then for patients who still have to go by whatever the parents say, meaning parents determine whether the patient's having symptoms or not, I don't feel that comfortable with track 1. So I find good patient candidate for me is a little older, teenager, and who have good understanding. They listen to me, they understand what I teach them. And then they have never been in a situation when they had to do albuterol back to back, ER. Not that they cannot do track 1, because I will show you why they can do track 1. But I am still selecting patients to gain experience, real life experience on my own. And then later on, maybe I can expand patient selection. Did I answer the question? Okay. And sometimes it's not a new patient. It's a follow-up patient who might have used, say, Symbicort or Dulera the old way that I ordered, an asthma, and then asthma becomes really well controlled, or sometimes I see that the adherence is dropping, then I tweak the management and kind of fall on track 1, and then things work. And many teenagers like to have one inhaler. Another good candidate would be some families are very much confused when they have more than one inhaler. Multiple caretakers. Sometimes it surprises me that I have been following this patient for a few years now, and then, wow, still couldn't tell which one's Flovent, which one's albuterol. And we have poster in our clinic, all the pictures of the inhaler that we use, this one or that one. So people who are confused between, they end up using albuterol every day and Flovent as a rescue. So those patients will benefit from one inhaler.
One thing, Chuanpit, I think, I don't know whether you have that experience or not, is even South Dakota Medicaid covering Symbicort, are they filling more than once a month? Mm-hmm. Do they allow more than once a month?
I have a trick for that. So, because one inhaler comes in 120 doses, yep. And usually the maintenance that I order 2 puffs once a day. Although the dose recommendation will come later on. I'll show you the dose recommendation. So if they use 2 puffs once a day, 1 month, they only need 60. So they actually have 60 more puffs.
Yeah.
And these patients really from these studies, they end up not needing that many extra doses. Like my patients would come back to me and I say, so how many puffs of the as needed did you use the last 30 days? 2 puffs, literally, or 4 puffs. So most patients don't need the as needed much because the asthma become better control. So I say, you picked up your first inhaler today. And then 3.5 weeks from now, you go pick up the second one. And then now you have 2 inhalers, 1 full, 1 half used. And then the next month, you go pick up 1. Now you have 3 inhalers. So they just have to manage that inhaler. And then when the other day, I just switched a patient from traditional to the new track. And parent asked me, so what do I do with my albuterol nebulizer treatment? Like, can I still do that? I say, be my guest. If you ever get into a situation when you feel that, you already did asthma action plan and you feel like, I think I need to do albuterol neb, go ahead and be my guest. I don't order a new albuterol neb if I think the patient is a good candidate for track 1. But the people who already have it, I'm not gonna say throw it away. So I think we kind of touch base on a lot of things appear on this page. How to prescribe low dose ICS formoterol. So the way they recommend, look over here. This is a different delivery method. Don't look at that one. Look at this one. So Symbicort, budesonide formoterol in US come in HFA, traditional meter dose inhaler, only 2 strengths. The formoterol part is the same, 4.5 micrograms per puff. The difference is the budesonide part, either 80 or 160. So remember, this is 12 years and older. So the recommendation is, if you're step 1 and 2, only as needed, remember, 1 inhalation whenever needed, 1 inhalation. If you're step 3 or more, don't worry too much about detail between 3, 4, 5. Take 1 inhalation twice a day or 2 inhalation a day or 1 inhalation once a day, and then 1 inhalation as needed. And then basically steps 4 and 5, you take higher maintenance than step 3, that's all. Don't worry too much about that. 1 inhalation as needed. And you can also take before exercise for people who have exercise-induced symptoms. And this is the detail. You can look at it if you cannot remember today. So before they made it clear, I used to struggle. So as needed, how many puffs? How often? This is long acting. This is not short acting. How many puffs total? Can they, is there a limitation? So if you are 12 years and older, you are limited at no more than 12 puffs in 24-hour period.
Including maintenance. Okay.
Total. 12 puffs in 24 hours. And I have not had a patient telling me that they need that many puffs. If you are the second group of patients, meaning 6 to 11, or for an AEEP 4 to 11, you don't go over 8 puffs in 24 hours. Okay, so 12 for the oldest people, 8 for the group in the middle. And when you use it as needed, according to the guideline, 1 puff, and you only have to wait 3 minutes. Why? Formoterol has been studied comparing to albuterol, comparing to salmeterol. The effectiveness onset is comparable to albuterol. Within a few minutes, you already got bronchodilating effect, and then it is well maintained. I don't have the graph with me today. Salmeterol is different. Salmeterol takes longer time to start effect. That's why salmeterol is never used as a rescue medication. They even study patient's perception. And some study may say patient like the feeling of albuterol better. Some studies say they like the feeling of formoterol better. So in conclusion, no significant difference. So because formoterol start working within a few minutes, just like albuterol, it's not peak yet, but it starts working. And the graph shows shot of FEV1 together with albuterol and then maintain. That's why you take, they recommend low dose, just one inhalation. Take one inhalation. Wait, I tell my patients, wait at least 3 minutes. If you feel like I need more, I still short of breath, I'm wheezing, you take one. And then you wait at least 3 minutes. See if you still need more. I still need more. You take one. In one event, do not take more than 6 puffs total. 6 puffs per event. And when do you tell patients to seek medical attention? If the patient needs more than 6 puffs that day, for the oldest people, the oldest group, 12 years and older, they should seek medical attention. And you could tell them what you want them to do. Oral steroid, seek medical attention, or what? And then the younger kid who's on this regimen, if they need more than 4 puffs that day, they seek attention. Basically half of the total, okay? And this is more in detail of what I mentioned. This is what we talked about. And emphasize that most patients need far fewer doses than this. I have not had any patient coming back to me telling me they need that many. This is what we talk about, having one inhaler at home, one in the pocket or in the bag. Oh, there's one thing that I learned. We typically tell patients to rinse off this inhaled steroid after using. So they did study specifically to as needed use. There's no increased chance of oral candidiasis if you don't rinse your mouth. So the recommendation is when you use your maintenance dose, rinse your mouth because you have to use that every day, right? When you use your as needed dose, you don't have to rinse your mouth. That is so that the patient does not hold back on using as needed dose because I don't have a way to rinse my mouth. You know, some patients come back and tell me, I don't brush my teeth every night, so I kind of skip the night dose because I don't brush my teeth. I say, go ahead and use it. All right. This is the new action plan. I haven't made one I am in the process of making one for my clinic. You can look, it's hard to see, right, Aaron? Yeah, it's hard to see here for me. So it's just read through it, you know, on the slide on the website. It makes sense. Basically, it's green zone, what do you do? And then yellow zone, it's basically the 1 puff as needed, like I told you. Red zone, you still do the 1 puff as needed while you wait for ambulance to come. And then you can click when you want the patient to start oral steroid. I think Amit is trying hard to see. I let you see it for a minute. You see the red zone? Take 1 inhalation of budesonide/formoterol, wait 1 to 3 minutes. If there's no improvement, take another inhalation. And they already study about safety. That's how they came up with how many total. And they look at chance of cardiovascular side effect, dysrhythmia, yada yada, is not any greater than albuterol. I'm gonna touch this briefly because time is limited. This is 6 to 11-year-old. And the difference between this and the last group, you can use MART for step 3 and beyond. For step 1 and 2, for GINA, they actually give different recommendation from the adolescent and adults. Step 1, PRN, low dose inhaled steroid with short acting beta 2 agonist. Step 2, daily low dose inhaled steroid and as needed, short acting beta 2 agonist. Now, there is a new inhaler coming up soon. It has been FDA approved, but commercially, it will be available soon. It is budesonide, 80 micrograms per puff, combined with albuterol, 90 micrograms per puff. And it's gonna be called Air Supra. So that could take over albuterol only. And I think that is also another very good inhaler in the sense that for patients who are not adherent to maintenance, every time they need albuterol, they get steroid. Every time they need albuterol, they get steroid. Just like the Symbicort. Every time they need formoterol, they get steroid. Okay. For NAEPP, you can actually use the teenager stepwise approach, meaning you can use MART or SMART all the way to 4 years of age. But they are on the lower dose side. This is the youngest people, 5 years and younger. For NAEPP, younger than 4. This is a different, unique group of patients. The stepwise therapy, pay attention here. Consider this step for children with infrequent viral wheezing and no or few interval symptoms. Those little kids, they're fine, and then they catch viral infection, and then they go into asthma flare or wheezing, bad cough, and they need oral steroid. I'm sure Aaron sees those all the time. If they only have this very few and far in between, then they belong in step 1. And consider intermittent short course inhaled steroid at the beginning of viral infection. That was a paper years ago using budesonide 1 milligram twice a day for 1 week, starting first sign of URI. And that is step 1. You don't have to do budesonide nebulizer treatment. You can do any inhaled steroid for this step. And then step 2, for little children, pay attention here. This is basically having episodes 3 or more per year. Kids here having 1 or 2 episodes a year. Kids, 3 or more episodes a year come to this step, which is low dose steroid. And then as needed bronchodilator. And then, some people want to try montelukast. It's not as effective. It works sometimes. That is a choice. And then step 3 and beyond, pretty straightforward. Higher dose inhaled steroid, or add long-acting beta-2 agonist, or inhaled steroid plus montelukast, so on and so forth. So I think this is just so many techniques, so confusing. If we could just do one technique, one inhaler, life is easy. And it talks about environmental problem, how the CFC was really bad for the world. HFA is not totally okay. So it talks about how to make the world greener. One last thing, just before we finish. There are 2 terms that I think is important, although when I do electronic medical record, I don't really get to do exactly what I want to do, because for ICD-10, we still have to grade the asthma, and I change my asthma grading from time to time, just for the matter of communicating with Aaron or with Dr. Whalen. Difficult to treat asthma is different from severe asthma. In what sense? Both groups, they are prescribed everything, okay? And their asthma symptoms are not under control. The difference is difficult to treat means they're not adherent. Severe means they are adherent and still out of control. That's it. We have a lot of difficult. We have quite several difficult to treat asthma patients. So, the end. We have 5 minutes till 1 o'clock. Questions, concerns? So it's okay to freak out.
Obviously, it's a huge change because for eons, I've been taught, make sure they don't screw up their long-acting inhaler because that's how we kill people with asthma. And now, Adderall maybe didn't exist at that point, and it was only salmeterol.
So it was a more like solo use of
Yeah.
long acting.
But even then, now, you study it, theoretically, your immediate use, a long-acting salmeterol, if you have salmeterol only, it probably would be beneficial. But
For Adderall only.
yeah, then we don't have, but if you had messed it up somehow, you had gotten a long-acting one instead of.
In terms of safety.
Right.
And effectiveness in terms of onset.
Right. It's interesting though that the American version actually, that middle age group is almost pushing the GINA updated group more than the GINA track one is.
Yes. And
it is obviously easier.
It makes sense. I think Gina just wait for more research data on younger kids. You know, when they did the research, they chose certain age, and then they cannot give global recommendation without specific data on specific age. I think NAEPP add some common sense to it because FDA approves long-acting beta-2 agonist officially down to 4 years of age. We don't usually use long-acting beta-2 agonist under 4 years of age. It is rare. Well, at least for me, you know, I think some pulmonologists feel more comfortable using it, but because of FDA approval and limited data in younger than 4, we use long-acting beta-2 agonist from 4 years and older. So I think an AEPP adds some common sense to it, because think about the middle age group. If you're gonna give step 1, that new thing, air supra, right? It's budesonide plus albuterol. And then they move to step 3, like asthma severity can change. And what if they change to step 3? Now you have to give them Symbicort, you know? So it's like not the best way to deal with having to change inhaler. So I actually think an AEPP guideline for that matter makes common sense. And I do use it, not as often, because the younger the kid, the more I'm concerned about, you know, how often they can tolerate it, and also a cumulative effect of steroid. There was some study looking at height for kids on daily low-dose inhaled steroid plus as-needed SABA versus as-needed budesonide formoterol. So this group is 1 point something centimeters taller than that. Don't ask me how the study was done and all that. This is a lot of study, but the result, because at the end, the accumulative dose of inhaled steroid is lower on the budesonide formoterol group than low-dose inhaled steroid plus SABA group. So for growth, it's great. You know, so I think younger kids, I don't know yet, the 4 or 5-year-old, I don't know yet how it's gonna impact the marks, the smart system, whether it's gonna impact their in adult height and how. I don't know yet. Any more questions, comment? Thank you for coming.